like the title of this session. Are you ready? Because I think we are ready now. We are ready to put changes for our patients, for the global population of our patients. Because we've been facing issues, multiple issues with the RSV. And now, only now, we have solutions for RSV in terms of vaccination. And that's the idea of value of the RSV vaccine, especially in the older population. Those are the people who suffer a lot from RSV, especially those with comorbidities. And I'm lucky enough to be with a panel of speakers, with experts on the subject matter. I'll just introduce myself. My name is Dr. Riyad. Canadian board certified in internal medicine and pulmonary with a fellowship in asthma and sleep from University of Toronto. I run the severe asthma clinical service at King Fahd Medical City. So this is a disclaimer. I'm not a GSK employee. This presentation might contain promotional content. So this session is to advance the understanding of RSV impact on our patients, especially people at home, specifically those with cardiovascular disease, pulmonary diseases, and older patients. This will be reviewed by our panelists. We'll review the recommendation, certain guidelines, and the significant role for healthcare providers entering the new era of vaccination process. We'll also emphasize the importance of vaccination and the urgency against RSV patients, older patients above the age of 60, and focusing on more of the guidelines on those patients. So now we'll go with a video presentation by our team. Totally, this is now my episode, scheduled for vacation. So it's really talks about the impact of RSV in those special populations, people above the age of 60, especially when they have more cardiovascular and respiratory diseases. And rather than them enjoying their time with the family in their autumn of their age, they face the RSV and its harm on them. And it's a deadly virus. This will be shown by our panelists later on. It also showed us the effect of RSV vaccination in terms of preventing those complications on such patients. So we have exciting panelists with us. We first going to talk about the age-related decline in immunity and RSV emerging burden in the elderly. This will be done by my dear friend, Dr. Luay Sudan, who is a family medicine consultant who did his residency and training in the Baylor Specialist Hospital and Research Center. So please welcome Dr. Luay to the podium.
Assalamu alaikum. Thank you, Dr. Lehebi, for the nice introduction. Thank you, TSK, for organizing this amazing day. And thank you all for coming in Friday after our weekend. It's really important, and hopefully today we'll learn something that we will help our patient in the near future, inshallah. Prevention medicine is a huge thing, and always prevention is better than cure. Primary prevention is immunization, and there is a lot of evidence that immunization is helping to decrease. The most important thing in prevention is decrease mortality. I'm a geriatrician, and as aging, and all of us we will face this, inshallah, in a healthy way. Saudi Arabia is now, we are proud that our age is extended to 78, and we are hoping to reach to 83. We have a lot of meeting with Ministry of Health. This is the goal. We increase it from 74 to 78 recently, and we are going to this age. And when we reach this age, we want to be as much as functional. But age, there is a lot of changing. We cannot prevent, as other diseases, osteoarthritis. This elderly going to have more infection. We have the T lymphocyte and B lymphocyte. The T lymphocyte, we have the naive cell. We are ready for any antigen to attack. In middle age, we have more memory cell. The ratio between memory cell and naive cell has become more memory cell. And with aging, this cell become aging less functional, basically. So we are not protection from any antigen as when we are young. And other problem with aging, as you know, the thymus is shrinking with age, whereas this is the one producing the T lymphocyte, and this is another risk factor to decrease the immunity. In bone marrow, with the antibody is the same. There is decreasing in immunity. There is more memory cell in aging, so that make the immune system more prone to infection. Other phenomena happen with geriatric group, elderly group, and it's been studied in a lot of vaccines. The response of the vaccine to produce immunity is not as young population. Multiple study in influenza vaccines, the frequency of cytotoxic and T4 cell is not responding to vaccine as younger. The antibody-specific antigen is not. The third one here is the hepatitis specific. This is a study that shows they give the hepatitis vaccine group at age 33, another group about 60, and there is a huge difference in response. And the potency of antibody with elderly become less. So this group they have multiple reasons to born to more serious infection. how we can overcome these problems. Herd immunity. Which is herd immunity? When you vaccine more people with immunity, they call it community immunity, will decrease the risk for others to be infected. If you are living with 100 people, if most of them they get the vaccine, that the vaccine will not transmit it from one to one. It's not important only for geriatric, it's also important for newborn because they are the most people that get infection. So if you vaccine the elderly and most of the population will decrease the transmission of the virus during the community. Other way that we can overcome the problem with decrease in immunity in the geriatric group is giving higher antigens, like that we are doing with influenza now, higher dose and the old zoster vaccine. The route of giving the vaccine is being studied in geriatric population, especially with influenza. When you give intradermal vaccine, it gives more effective, more subcutaneous or intramuscular. Adjuvant system with the vaccine showed a lot of effectiveness in a lot of vaccine. The Shingrix recent vaccine shows a huge effective and it's lasting for years because of the adjuvant system. And booster vaccine has a lot of vaccine. As you know, we give tetanus, the Tdap every 10 years. So all these measures can help to boost the immunity with the geriatric that we are agreed now their immunity is decreased and their response to the vaccine is not like the younger population. Burden and elder. As you know, the fact that the RSV, the influenza, all this is droplet infection by contact. Most of the time, it's coming in upper respiratory as runny nose and cough for a few days and goes. But we have to agree in geriatric group, which may go to lower respiratory tract infection and cause a lot of problems. As I mentioned, it's contact droplet. The mean basic reproduction number, what does that mean? If somebody infection, how many other people that he will infect? So you have the R0 is 1, that most of the time this infection will be limited and die because 1 and then will go. But more than 1, the risk of transmitting in the community is more and more. If the R0 increase, the more the transmission of the virus will be more. R3 is considered moderate to high compared to other. Influenza is 1 to 2, for example. So the mean basic protection number is the number that tell us how contagious is the virus or the bacteria. The more the number is more dangerous for transmitting this virus. In young population, healthy population, the symptom and the transmitted period to be infectious, the individual is usually between 3 to 8 days. When your immune system is suppressed, you can be infectious up to 4 weeks. Think about it, if you have an elderly, his grandson, and the community surrounding him, that increases the risk. Personally, I face, it's really serious disease. We saw it a lot with younger population. It's happening with my daughter, true story. Years ago, my youngest daughter, I almost died because of that. She admitted in the ICU because of that. So giving the geriatric, the vaccine, it's protect your community. You don't know whom you will protect. You may protect a close member for you. Coming to the virus itself, it's an RSV, enveloped non-segmental RNA virus. The main thing in this slide is how the vaccine will work. This virus has two main proteins, namely the G protein and the F protein. The F protein is in two subtypes, the common subtype, the RSV-A and RSV-B. The F protein is the same, so the subtype is depending on the genotype, and the G protein genotype, and this is the G protein is responsible for attachment the virus in the cell, and the F protein is important to fusion and become too stable, from pre-stable state before entering the virus. And this protein will make it stable when it gets inside the cell, then replication and become more potent. The vaccine is targeting the F protein before the stability of the virus to go inside the cell. They catching the virus before the stability, before entering inside the cell. It's a common, and it's happening every year. And the long immunity is not potent, even for young or even in the young adult or pediatric. They get infection, they get immune, adapted immune system for few, but when it's come, they expose next year, there's a good chance they will be reinfected. So whom is the people that has the most chance to have complication is the younger in the left side and the elderly. Younger because they didn't have adaptive system, so when they get the infection, it's first time, so they have risk to have severe, as we see it. Anyone dealing with pediatric or infant, a lot during the season of the RSV, a lot of admission in ICU, it's because of this virus, because it's really potent and can cause a lot of problem. Then when we're getting older and older, we get the adaptive system and our immunity become more mature, so we get symptoms like flu or runny nose for 2-3 days, and it's gone away without testing or going to the hospital. As we mentioned, geriatric is different. They become aging and the immunity become low, so they are born to have severe disease. As you can see, majority of admission is in geriatrics. And the most important message today is how many of us, when we work in urgent care or primary care or secondary care, checking for the RSV. Rarely we do the test to see if somebody admitted to the hospital come to the emergency with a flu symptom, even if he has a pneumonia. Rarely we check for the RSV if it's there or not. We treating the symptom, either upper respiratory tract or pneumonia as a disease without knowing sometimes that cause. We will do checking for culture, maybe for bacteria, but we didn't check usually for RSV except for severe disease. Most of death is happening with geriatric. It's rarely cause mortality with pediatrics, up to 89%. This is huge. As we keep mentioning that the symptom usually runny nose for a few days and go, but in our geriatric, our elderly, is a different scenario. So it's go to the lower respiratory infection. It causes acute exacerbation of underlying disease like COPD or asthma or congestive heart failure. It causes, if they are already they have a risk of cardiovascular complication because of the age and other comorbidity disease. They are not needing to have another disease to trigger the cardiovascular disease. The studies increase hospitalization and unfortunately death. So basically, contact droplet coming in the cilia epithelial and upper respiratory tract infection, sometime with the GF protein, G protein is binding to the epithelial cell and then go inside the lung, replication causing necrosis, increasing the airway obstruction, causing mucus plugging, and can cause and the lung compliance become decreased with time. So again, older age by itself is a risk factor for complication, hospitalization, admitted to ICU, and death. If the patient has comorbidity, and how many of our patients above 60, they don't have diabetes or asthma. COPD in our country, luckily, alhamdulillah, not like the Western, but I think the booming is coming with all this number of people, unfortunately, smoking. So we need to keep it in mind. I think COPD, it will come more and more. Currently, the prevalence or the cases that documented that we have documented COPD is not much, but I believe it's coming soon. So we need to be careful, especially in the primary health care, because when they go to the specialist, it's become late. And if anyone with the immune system is low, is risk for complication for RSV. By decreasing the immunosenescence, the elderly not only born for low immunity, they are born more for cancer. As we see, majority of cancer coming with the elderly, and also with autoimmune disease. So we have in geriatric group really having a lot of risk, and mostly will benefit from any protection. This study done in the Western were documented, and they do a research. As I mentioned here, if we do mass research to see how many RSV positive or negative, we find the ordering RSV test is really low, or the viral profile during infected people. But still, even we are underestimating the problem and underestimating the investigation, we have about 5.2 million cases of RSV. We have 470,000 hospitalization and 33,000 deaths. I seriously believe this number way more than what is documented here. I'm a geriatrician. I see a lot of people, they come with pneumonia. We try to treat it. If we successfully, they pass the period of pneumonia, they have delirium and increased mortality all over. Geriatric patients, when they become older and older with a lot of comorbidity, dealing with geriatric, you know that if they have pneumonia or UTI, in some cases, it's end of story. The level of the living, the way of their functioning, cognition is declining significantly. So one pneumonia, the elderly who was completely functional at 70, 65, 80, after that it may completely different for him and for the caregiver also. So, in summary, RSV infection is often non-considered in differential diagnosis. This is fact. We don't, especially our work in urgent care, in hospital, in primary care, we don't investigate a lot. So this may be alarming for us to consider it in diagnosis. And if you consider it in diagnosis, we will investigate for it. The robust surveillance system is not applying anywhere in Western or here. We agreed elderly having a high risk, age by itself decrease the immunity, and if you combine this with comorbidity, then the risk is very huge. Used for what? For unfortunately death or admission to the hospital or intensive care units. As we mentioned, it's a contagious. If reinfection can infect everyone, get infection can transmit the infection to 3 people surrounding him, and the infection period usually 3 to 8 days. But if you are with low immunity as geriatrics, the infection period may go up to 4 days. Okay, so let's recap and see if the message hopefully received. If you can scan, there is a question. So I ask you please if you can scan by your phone to answer the question. It's running? Okay. So, are the majority here are primary caregiver, either GPs or family medicine, or more like specialists? Can kindly I have the people with primary care? Okay. Even if you are not a physician, but you're still in the primary care. How many are pulmonologists here? Other specialties? What specialty? Cardiologist? Nephrologist? Yes, welcome. So we're dealing with a lot of geriatric patients. Yeah, it's high risk. Geriatric population with any other coronary heart disease, renal disease, lung disease, they are high risk to have. So 95 was good. The questions, can we see the question? Which of the following factor increase person risk of severe RSV infection? So age, for sure. I've been talking for the last 20-25 minutes about aging. Aging by itself is causing the problem. Weak immunity. We said that if there's somebody already weak immunity, for sure. Another chronic condition, as Victor said, renal disease, coronary artery disease, lung disease, cancer patient. Okay. Who's the next question? Still running. Okay. So I give you a hint. So hopefully the percentage will increase. So anyone, all the answer is true. So somebody saying the age alone is correct, weak immunity is correct, correct condition, but the right answer is all of that. Okay, next question. older adults, especially older than 60 years old, adults with certain underlying condition, and adults with weakened immune system can experience serious complication from RSV. Done. Again, 90% good number. Again, the one who said pneumonia or exacerbation of COPD or lung is correct, but the correct answer is all the above. Last question, I promise. You can hold this question also. Halas? Okay. So, thank you, and I just bottom line is elder people as a high risk, and they can cause mortality. This is a fact. They decrease immunity for multi reasons, as we mentioned. People with comorbidity, immunity is the vaccine is here and saving life, not only for elderly, but by herding immunity or community immunity is prevent our pediatric and our geriatric. Thank you.
في أحد الأيام كنت أجالس حفيدي البالغ من العمر عامين، والذي كان يعاني من نزلة برد أو هكذا كنا نظن. وكان بعد أيام قليلة من ذلك عندما مرضت بحمى شديد، سعال سيء، وشعرت أنني لست على ما أرام. عندها أخبرني طبيب الطوارئ أنني مصابة بفيروس RSV. أول شيء تفوّت به كان لكنني بالغ، لم يكن لدي أي فكرة عن إمكانية إصابة شخص بالغ بفيروس RSV. عندما اتصلت بطبيب الرعاية الأولية الخاص بي، قيل لي أن لدي فيروس وأنه ليس له علاج. طلب مني أن أكتب الأعراض وشراء دواء للسعال دون وصفة طبية. أعلم أنه بالنسبة للكثير من الناس يمكن أن يكون الفيروس المخلوي التنفسي RSV خفيفا جدا، ولكن بالنسبة لي كان الأمر شديدا للغاية. كانت حرارتي ترتفع ما بين 38.5 إلى 39 درجة مئوية، وكان السعال خارج السيطرة. كان السعال صباحا ظهرا ومساء. كانت هناك أيام نادرا ما نهضت من السرير، غسيل أسناني أو حتى تمشيط شعري ما كان ليحدث. لقد كان وقتا مدمرا بالنسبة لي. لأول مرة في حياتي أشعر بالشيخوخة. لقد فاتني الكثير من الأنشطة في كنيستي، في مدرسة حفيدي، ولم يعد بإمكاني أن أكون امرأة مستقلة كما كنت. في بعض الأيام كنت فيها مريضة لدرجة أنني اعتقدت بصدق أن هذه هي النهاية. كان الشهران الأولان مع RSV صعبين للغاية. في الشهرين التاليين بدأت أشعر بالتحسن، اختفت الحمى وظل الشعر مضحك، لكنه لم يكن بنفس القوة. وأخيرا بعد 4 أشهر أستطيع أن أقول بصراحة أنني قد انتهيت من RSV. أريد فقط أن أشارك الإحساس بأنني ممتنة جدا في كل يوم بأنني اجتزت هذا المرض. أريد أن يعرف كبار السن بأن RSV يمكنه أن يكون مرضا خطيرا جدا، ولا أتمنى أن يمر أحد بما مررت به.
So this is an important video. So it shows the effect and the impact of RSV. We always in med school thought of RSV as a virus that affects usually the younger population, the infants, the toddlers, etc. But it's really its damaging effect are people like Debbie, where it affects them in multiple ways, whether because of their age or because of their comorbidity, namely the cardiovascular and pulmonary diseases. It's something that Dr. Jawahir Al-Ateli will talk about. So she will talk about the RSV severe outcomes, especially in these elderly gentlemen above the age of 60 and the increased RSV risk with chronic diseases. Dr. Jawahir Al-Ateli is a consultant in infectious disease at King Faisal Specialist Hospital with a special training in Hamilton in HIV and AIDS patients. Dr. Jawahir, the floor is yours.
السلام عليكم. السلام عليكم everybody and good afternoon. Thank you all for coming and special thanks for GSK for giving me this opportunity to be in this very nice event among other distinguished speakers. So today I'm going to discuss with you the case that I face in the clinical practice, and then we'll talk a bit about the RSV burden in adult population, especially for those who have the underlying comorbid disease, in particular pulmonary and cardiovascular. So a 72-year-old gentleman who is known with the full package of comorbid diseases that we tend to see in clinical practice: diabetic, hypertensive, and ischemic heart disease, percutaneous pacing, and he had a lower ejection fraction of around 25 based on the most recent echo. He presented to the hospital with 1 week of respiratory symptoms, especially shortness of breath that was progressed over the past few days prior to his visit to the emergency. He had viral prodrome, as we call it, infectious disease, prior to the worsening shortness of breath, so mainly runny nose, sore throats, and low-grade fever. He reported that the family also was having flu-like illnesses. In particular, they have toddlers and a younger child who had a respiratory viruses 2 weeks ago. He came to the emergency department. He was assessed by the medical on call, and he was very tachypnic, desatting, requiring supplemental oxygen. He had also clinical sign that is going with a heart failure and chest X-ray showing bilateral infiltrations, and he had a specific interstitial infiltrations in the upper lobe as well. So he was placed on oxygen, given a diuresis, and as we all know, most of the patients who presented to the emergency with a question of pneumonia, they get Tazo and Vanco. And they did the investigation. They had the WBC count, which was normal, so it was not going with the bacterial infection. He had a normal platelet count. His creatinine was measured like his baseline. Cardiac enzymes were negative, and CRP was also 40. As we know that in the emergency we had a rapid testing for COVID and influenza A and B, and both came negative. So he was admitted to the CCU, and he was placed in high-flow nasal cannula. He was covered with the antibiotic, but within 24 hours his microbiological study came out. His gram stain for respiratory culture was negative, so it was not suggestive of bacterial infection, although his presentation also do not go with bacterial infection. And then the multiplex PCR that we tend to do with severe respiratory forms or severe respiratory illnesses came to be positive for RSV. That led to hospitalization in the CCU for over 10 days just to manage his heart failure and to give us supportive measures and supplemental oxygen for his RSV infection. So could we prevent that? The answer is yes. So looking into the rate of complications in patients who had an underlying comorbid diseases, in particular senior patients, the outcome in adults over the age of 60s with hospitalization in comparison to those who had influenza, especially in influenza vaccinated populations, there are more higher odds of RSV infection to cause more average length of stay, more hospitalization, more ICU admissions, and unfortunately also secondary bacterial infections, underlying primary disease exacerbation, and higher odds of mortality within a year after the infection with RSV in comparison to vaccinated influenza population. The long-term impact that was looked into several cohort study that includes tool to assess the quality of life and also to assess the functional status in senior adults infected with RSV, reported that those who had an RSV infection tend to have a lower functional status and significant decline in their quality of life after the infection with the RSV. And that has been seen in one of the studies that includes around 271 patients that they look into the pre-hospitalization with a viral RSV infection and those also after 6 months of discharge, and they found that there is a significant decline from 40 to 32%. So older individuals hospitalized with RSV tend to have acute decline in the functional status in the early stage after discharge from the RSV infection, and also they have a significant decline that continues to occur until 6 months after their discharge from a baseline prior to the event of having an RSV infection. So looking into retrospective cohort study in China that included around over 200 patients or 600 patients that were age, or they were above 75 of age with RSV infection. In the study population, almost 87% of those, they have more than one serious comorbid infection. And they have also 35.6% of them, they were having chronic lung disease, in particular COPD, bronchial asthma, and chronic bronchitis. And they look into certain outcomes, which is include all-cause mortality and the rates of hospitalization. And there were significant increase in the all-cause mortality by 9.1% in the 30 days and 11.9% within 60 days from the RSV infection. And their direct cause of death were either related to secondary bacterial pneumonia following the RSV, and this is very common that we see in senior populations as well as populations they have a comorbid disease. They tend to have post-viral bacterial infections, underlying disease exacerbations such as COPD exacerbations, acute cardiovascular events, and also a decline in their underlying pulmonary disease. There were a significant amount of patients that require supplemental oxygen in early stage of the RSV infection, and some of them would require after discharge also supplemental oxygen, and they became oxygen dependent. And definitely, if you have someone with comorbid diseases who has an underlying lung or cardiovascular events, if they develop any respiratory infection, the chances they will require longer hospitalization and expose them to a significant morbidity and nosocomial infection is going to be high, and the median hospitalization in RSV infections with underlying comorbid disease reach up to 12 days. So RSV and other associated lung disease, looking into in particular COPD and bronchial asthma. So in COPD, they are 13.4 times more likely to be hospitalized with RSV infection, and 80% of among those hospitalized at risk to have a COPD exacerbation, and they can be exposed also unnecessarily to antimicrobial agents, especially in most of us would cover patients with antimicrobial, although there was no evidence of bacterial infection, and this will lead to toxicity and increase the development of multi-drug resistance pathogens. In bronchial asthma are 3.6 more likely to be hospitalized with RSV infection, and around 50% of them will experience bronchial asthma exacerbation during hospitalization with RSV. Looking into the cardiovascular, the patients who had a congestive heart failure or underlying cardiac disease are 8 times more likely to be hospitalized with RSV infection. And having RSV per se will increase the risk for them to develop cardiovascular events, to develop myocardial infarction and arrhythmias, and eventually la qadar Allah death. Diabetic patients are 11.4 more times that they will be hospitalized with viral illnesses, in particular RSV, and diabetic patients are 6 times more likely to be hospitalized with flu and flu-like illnesses in comparison to general population. So talking about RSV infection in COPD, as you all know that COPD exacerbation with underlying or infective agents, that they tend to have a longer hospitalization in comparison to those who do not have a COPD exacerbation related to a viral infection. They will also have a significant decline in the pulmonary function test when they have an infective-related COPD exacerbation in comparison to those who had a COPD exacerbation without the infection. They will have also a greater degree of hypoxemia and a greater airway inflammation, and with the aggregations or recruitment of inflammatory cells within the lung epithelial cells, that can also lead to more edema, exacerbation of the underlying disease, and that will also impair the clearance of the viruses, and they will tend to shed the virus for a longer time. On the other hand, bronchial asthma patients, they will tend to have more hospitalization when it comes to concomitant RSV infection. The RSV or viral infection will enhance the responsiveness to allergens, and it will also alter the antiviral immune response in asthmatic patients, and that will lead to more airway edema, exacerbation of the asthma, and also destruction of the epithelial cells and recruitment of certain inflammatory cells and interleukins, and that also can make the underlying lung disease in COPD and asthma much more worse. So to summarize, for the respiratory conditions, older adults with COPD and bronchial asthma are at increased risk of severe RSV disease, and there are a higher proportion of older adults hospitalized with RSV, that they will experience either a COPD or asthma exacerbation during their admissions or hospitalizations with RSV infection, and they will have also decline in their pulmonary function test when it comes to concomitant infections with viral illnesses, in particular RSV. Shifting gears to the cardiac conditions, we all know that respiratory infection and cardiovascular disease or viral infections in general can precipitate heart failures and cardiovascular events, and especially on those who had an advanced cardiac disease. So those who had an underlying cardiac disease are at increased risk to develop severe outcomes from respiratory infections, especially RSV. Upper respiratory tract infections, or RSV in particular, they are in cardiovascular patients. They are more prone to have complications. They can have congestive heart failure or worsening functional status of their cardiac status, and they also can lead to myocardial infarctions, and eventually that will lead to more hospitalization, longer hospitalization, stay exposure to nosocomial infections, and that will carry a higher risk of morbidity and eventually mortality. We all come across through our readings that if you have a viral infection, especially in those who had a cardiac disease, it will enhance specific pro-inflammatory cytokines, and especially in those who had an underlying coronary artery disease and they have a plaque in their coronary, there will be disruption of the plaque, and then probably platelet aggregation and development of thrombosis, and they can have a cardiac event or myocardial infarction. And overall, a viral infection with this pro-inflammatory inflammations, they can develop myocardial infarctions and la qadar Allah death. Looking into those who had a chronic cardiac disease throughout the age group, even, and those who are more than 18 years or those who are less than 65, that we can see from this graph that most of the patients who had an underlying cardiac disease, regardless of their age group, they are more prone to be hospitalized with viral infection, in particular RSV infection, and this can be associated with longer hospitalization, progression of or a decline in their cardiac status, and also they can develop cardiovascular events. They are more prone to be hospitalized, and they are also more prone to have a congestive heart failure related to RSV. So to summarize the cardiac conditions, RSV might cause a cardiovascular complication in older adults with congestive heart failure, atrial fibrillation, and myocardial infarction. And they are also at increased risk to be hospitalized longer than others who do not have an underlying cardiac condition. And the overall survival rate can be poorer among those adults with underlying cardiac disease. So to diagnose RSV, in most of us, we don't do a routine RSV testing, especially when someone comes with upper respiratory tract symptoms in the outpatient setting. We tend to do it if the patients are hospitalized or admitted to the intensive care unit to find a diagnosis, and then you can rationalize your treatment based on the underlying cause of their hospitalization or ICU admission. The testing, there are no available testing as far as I know for RSV in the emergency setting, and most of it is through the multiplex PCR, which tends to be time and also costly. And we all know that there is no effective treatment apart from specific populations for the RSV, in particular lung transplantation and stem cell transplantation. So in most of those elderly individuals with underlying comorbid disease, the treatment of RSV is only supportive. But you all know that we have a preventive measures to prevent severe RSV infection, especially with the vaccine. And my colleague later will talk to you about the guidelines of the vaccine. So let's recap. Can you scan the bar? So we have around 2 to 3 questions to see were you awake ولا كنت بتحتاجوا glucose. Asthmatic patients are up to 3.6 times more likely to be hospitalized with RSV infection. Is that true or false? So 93% said it's answer. So we'll move to the second question. The rates of complication and severe outcome in older adults with RSV, in comparison to influenza, considered to be RSV has more severe outcomes. RSV has similar or worse outcomes. So for those who chose the similar or worse outcomes are correct. The last question. RSV increased cardiovascular complication and risk such as heart attack and congestive heart failure, acute coronary syndromes and arrhythmia, and chronic heart failure exacerbation, myocardial infarction, arrhythmia, or all of the above. So a good number had the correct answer, so show them the answer. With this, I conclude my talk. Thank you all for listening.
The world is facing a triple dinner. RSV. The world is facing a triple dinner. RSV, or respiratory syncytial virus, is a common respiratory infection that can cause mild cold-like symptoms. But it can also be a life-threatening disease, especially among older adults and patients with comorbidities like COPD, diabetes, and chronic heart disease. They are most at risk of severe symptoms, which can lead to hospitalization and even death.
So what we gathered for the past few presentations, RSV is very prevalent. RSV is very dangerous for a special population, especially the elderly and people with cardiovascular and respiratory disease, as shown by Dr. Jawahir. So it is not a benign virus. It needs to be detected, looked after beforehand, etc. And with this recap, I think that's what Dr. Luay, Dr. Sudan, we're going to talk about in terms of guidelines. So let me reintroduce Dr. Sudan. Hopefully his affiliation is still the same for the past half an hour. He's a consultant in family and take some specialist hospital. Will talk to us about the RSV vaccine guidelines and recommendation. Dr. Sudan.
Thank you. Ahead of the time, schedule time. As you saw in the small clip, I hope that we have one vaccine containing the flu vaccine, the COVID, RSV in once, because I know the struggling nowadays with anti-vaccine. If you practice in the clinic and you have the patient, you are the primary care, family medicine, you are the one who depending on you to prevent this deadly disease. So a lot of resistance, so we need to believe in ourselves that this is important. The recommendation is there and like support our idea or our recommendation for our patient by guideline. So do we have the vaccine now in Saudi Arabia? Do anyone start to give the vaccine? Perfect. So, as you know, luckily the Ministry of Health, when it comes to vaccination in Saudi Arabia, alhamdulillah, we are advanced. And as other vaccine, we are one of the first countries that we provided, and we provide it for free in most of the time for our population. In Ministry of Health, they have it as the other vaccine, and they recommended Ministry of Health for the vaccine for people above 60. This is from the website from Ministry of Health. So first of all, we hopefully by today we believe that the disease is deadly, and we believe the vaccine is work, and we have guidelines supporting our recommendation. So we have to strongly recommend and overcome the anti-vaccine campaign people with the idea that they have. So what about the global guideline? GINA, the Global Strategy of Asthma Management of Prevention. Every year they have their recommendation for this year, 2024. They mentioned the RSV vaccine, prevent RSV-related acute respiratory infection. The adjuvant RSV, this is the GSK vaccine, subunit vaccine, reduced upper and lower respiratory tract infection for anyone above 60, especially people with asthma. The ASIP recommended one dose of RSV vaccine for anyone above 60. What about the Global Initiative for COPD? So they ensure that this is a deadly disease, especially when somebody with COPD. So they recommended the vaccine for anyone above age of 60. The ADA, the diabetic by itself, decrease the immunity and impact the patient. So the ADA in 2024, the American Diabetic Association recommended the vaccine for above 60. The ASIP recommended anyone above 75 to give one vaccine. But if you are 60 and you have another comorbidity, as we agreed, unfortunately in our community, people with above 60, most of the time, they have comorbidity, either diabetes, asthma, congestive heart failure, or other diseases that decrease the immunity. So I believe most majority, as Minister of Health recommended, above 60, we need to give them the vaccine. This is an interesting recommendation. The Stikut, the German Institute. This is the guideline for the German population. It's independent committee that's giving every year the recommendation for the German population. And this year in 2024, they recommended all people above the age of 75 to give them the vaccine for everyone above 75. Again, if you are 60 with any other comorbidity, they recommended the vaccine. What is interesting in their recommendation as an independent, and this is the organization that gives the recommendation annually for the German population, they specify the GSK vaccine by multiple points. So this is between the brick, this is what they written in their recommendation. GSK RSV vaccine, the RSV F3, shows slightly higher vaccine effectiveness when they compare it with Pfizer. It shows most of the endpoint, but the mostly broad and overlapping coefficient therefore. So it's really more stronger in their review when they review the data. Data on the effectiveness against severe RSV-related lower tract infection, and this is important for elderly, defined among other things as incapacity to work for elderly or required respiratory therapy, which is really important for elderly, that if they need respiratory support therapy, that most of the time cause a lot of complication and prolonged complication. The data for this is only available with the GSK vaccine. At the time, only data on GSK RSV F3 vaccine are available in the duration of potency and its effectiveness for 2 seasons, for 2 years. The GSK RSV F3 is adjuvanted with ACE1E, and this is the only vaccine with adjuvanted vaccine, and we know that the vaccine with adjuvanted is really more stronger and more effective. So all the guidelines can support us, especially the first liner, to give the vaccine, and it's safe, the vaccine. I don't know if we have time to talk about that first reaction. The vaccine, as other vaccine, is really safe and is really effective. And the guideline for most of the recommendation, and most importantly, I think the Ministry of Health in our country, after reviewing all the data, they recommended and provided in all primary health care, and we have it in all the big hospital and all the primary health care.
I don't want to be a repeated record, but again, we showed not a benign virus, affects lots of people, especially the elderly with comorbidities. What Dr. Luay just talked about, everyone is recommending this vaccination. The Ministry of Health here, all the global guidelines, especially the ones dealing with the respiratory disease, so GINA, dealing with asthma, GOLD, dealing with COPD, and other comorbidities, so diabetes, etc., recommend this vaccination. Why? Because it works. And Dr. Schwartz will tell us how it works in terms of bridging the gap with the only adjuvant recombinant RSV vaccination. It's my pleasure to use Dr. Tino Schwartz, who is the head of the Institute of Laboratory Medicine and Vaccination Center at the Klinikum Würzburg. Hopefully I didn't purchase this name. Academic teaching hospital at the University of Würzburg in Germany. And he's been working as a principal investigator in this vaccination. The floor is yours, Professor.
Assalamu alaikum. Good afternoon to all of you. It's my pleasure to be here. Thanks very much for inviting me. We've heard a lot about the relevance of RSV. We heard about guidelines. And I'm lucky that we presented the German guidelines, because I think they are very important, because STIKO is considered to be one of the very important NIPEX-like ACID. So if we've got the blessing from STIKO, it's certainly something relevant. So I will present you the key data of RSV, and I was one of the investigators in Germany, and personally we had about 200 subjects in our trials for RSV, not just the efficacy trial, but also the other trials which go along with the recommendations. So So we all know that we've heard this in the talks before, that our immune system is getting older. We have immunosenescence. So the important point is to design a vaccine which can overcome immunosenescence. We have to add an adjuvant, because the adjuvant is the key story of the whole vaccine. And we've really seen here that the T cell functioning in the young ones is good. But the moment you get older, the T cells won't work the way you expect them. So we have to overcome this weakness, and this is achieved by adding an adjuvant to the vaccine. And we have very good experience with the adjuvant. We've got the same adjuvant in the shingles vaccine, Shingrix, and it works perfectly. And we've had very good experience with this for many years. So this is the combination, a recombinant non-live protein, the 3F3, which is considered to be the dominant part of the virus, and this has been added with the adjuvant, the AS01E, which induces a very strong B and T cell response. And it's important that the 3F is stable, which means there's no difference between RSV A and B in the 3F protein. So we just need one protein, do not do the bivalent protein against RSV A and B. The 3F, which has been selected for the use of this vaccine, works against both subtypes. Very important point, because it may be confused sometimes by the bivalent approach. This is certainly not necessary, because the 3F is stable and does not undergo any changes. So the age-related decline I've mentioned to you, this negatively impacts your immune system in the elderly. We need something to boost our T cell response, and we know that the T cells are very important for viral clearance and especially for reducing the disease severity. That's also very important. So if we can hit our T cells up specifically directed against RSV, we can certainly overcome the deadly outcome which have just been presented in previous talks, which RSV is associated with. So the reduced responsiveness to vaccination in older adults requires vaccines which are specifically designed to overcome the declines in immunity. So let's now talk about the key findings of the clinical trial with Arexvy.
خلاص دروسه
As you've heard, Arexvy is
Odată nu.
indicated for the immunization
Odată n-am
of
șchir
respiratory tract disease caused by RSV in adults 16 and older. We already have now the indication as from 50 onwards, also in Europe. And we're just about to also get the label probably very soon for patients with high risk for severe RSV outcomes in 50 plus. We're already working for the age group 18 to 49, where that data will come up next year. So we will probably, in the long run, we will have a vaccine which we can use for all patients who have a high risk for severe outcomes with RSV infection. But currently, we're just presenting the data in patients above 60. The trial started in 2021, and as you know, 21 was the year where COVID hit us all, and we were really surprised to have a vaccine trial against the respiratory tract infection in that year. But the company made the decision to go for it, and we were successful because we really could demonstrate efficacy. So the study comprised 25,000 subjects, split 1-to-1, placebo and the vaccine group. And the primary endpoint was to demonstrate the efficacy of this vaccine in the prevention of RSV LRTD in adults 60 and older in the first season. This was the primary endpoint. The confirmatory secondary endpoint was to demonstrate the efficacy in patients 60 and older over 2 seasons following a single dose or repeated vaccination. you can see here the split after 1 year. The analysis was done after 1 year, and we were really surprised when we got the results after 1 year because we had no idea what we would expect with a respiratory tract, with a vaccine against a respiratory tract infection. We all know that our efficacy data for flu as a comparison are much lower. So we were kind of expecting something in the range of flu. But the adjuvant alone probably gave us the idea that the results might be better. In fact, we were better. In the second year, the vaccine group was split in a placebo group, which was followed, and in another round of vaccine. And it turned out that the annual revaccination was not necessary. So one shot was sufficient over 2 seasons. So once again, primary endpoint efficacy in the first season, and key secondary endpoints were also looking at subjects with one or more than one comorbidity of interest. I will tell you later what they were. And also looking at the vaccine efficacy against LRTB and acute respiratory infection. Also splitting the efficacy in age group 60 to 70 and 70 above. Also looking at patients considered pre-frail. Additionally, we looked at the efficacy against the 2 subtypes, A and B, and then we collected safety data, reactogenicity and immunogenicity data. So I will present you the full set of data now. Looking at the demographic characteristics, you see it was even split between placebo and the vaccine group, females and males in the same proportion. And importantly, looking at the frail stages, it was variance between the 2 groups, and looking at the comorbidity of interest. And that's important because we were analyzing the specific efficacy against certain comorbidities. So 39% of the subjects actually had one or more than one pre-existing comorbidity of interest, which is associated with increased risk for severe outcomes. And if you look at the breakdown, we had 39.6% with one or more than one. We had 20% in 2 or more than 2, and 6.5% in 3 or more than 3 comorbidities. So it's very important to looking at these specific groups, because this is your daily work. These are your patients which you see in the office every day. So you really want to know how good the vaccine works in the prevention of LRTB for these various groups of interest, especially comorbidities. So once again here, breaking down the comorbidities of interest in numbers here, it was COPD 9%, it was asthma and chronic respiratory pulmonary disease was 9%, 70% had chronic heart failure, and we also had very good data on the diabetes group, which is also important because you have a lot of diabetes in Saudi. So diabetes is certainly one of the very important comorbidities of interest to look at specifically. So 23% had diabetes 1 or type 2, and 5% had advanced liver or renal disease. So the sub-analysis of the various comorbidities is very important. So what was the finding at the end of season 1? We had an overall efficacy in preventing RSV LRTB of 82.6%. This was the primary endpoint, so the primary endpoint was met. So the study had been successful, we met the primary endpoint, and the efficacy against RSV LRTB for patients with at least one comorbidity was 94.6%. This was a secondary endpoint, so we've proven that the vaccine works in patients with specific comorbidities. And these comorbidities, once again, were COPD, asthma, chronic respiratory pulmonary disease, chronic heart failure, and diabetes type 1 and 2, and liver or renal disease. So basically, we have a vaccine now available with high efficacy for patients with specific comorbidities, which would eventually, once they get infected, come down with severe LRTD. So now I'm giving you the individual results for the specific, for the secondary endpoints. As already mentioned, we had excellent efficacy against the severe LRTD, and this has been mentioned by Stico as well, that this specifically is a characteristic of this vaccine, and the bivalent vaccine does not have the same hard data on the prevention of severe LRTD. So 94.1% in the prevention of severe LRTD at the end of season 1 is really a fantastic result. Then for patients with pre-frail patients, we had an efficacy of 92.9%. In the older group, 70 to 79, we had an efficacy of 93.8%. We have limited data on the efficacy above 80, simply because the numbers were too small to come in with an adequate statistics. So, but seeing that the results in the 60 to 69-year-old was slightly lower than the 70 to 79, we can assume that the efficacy is also very good in the older ones. But currently we have no exact data for 80 plus, but the data 70 to 79 really give us a clue what we could expect in the elderly population. So we have an efficacy of 94.6% in patients with one or more than one pre-existing comorbidity of interest, and 92% in patients with two or more than two comorbidities of interest. So once again, your patients will benefit from the vaccine if they have comorbidities, and that has been proven by the trial. So what about the comorbidities of interest, breaking down once again in groups? We had one or more pre-existing comorbidity of interest. Total was 94.6, as already mentioned. But coming down specifically to cardiorespiratory conditions, here we had an efficacy of 92.1%. And for the endocrine metabolic conditions, we had an efficacy of even 100%. Once again, the diabetes is very important in Saudi. This is certainly very, very important news for your patients, because they can be protected against complications due to diabetes and RSV. What about the efficacy against the various subtypes, A and B? You see no difference in the efficacy between RSV A and B. Numbers are almost identical, so even if you look at acute respiratory infection or lower respiratory tract disease, there is the exact protection against the individual subtypes A and B. So we can capture both subtypes with the help of this free vaccine. So now I'm coming to an important point, which is duration. I mentioned to you the primary endpoint was season 1. We have now season 2, and we found out that giving a dose after 1 year did not increase the efficacy in the second year. So we do not require an annual vaccination. This has been clearly shown. And looking at the data here, cumulative efficacy over 2 seasons with one shot was 67.2% against LRTD, against acute respiratory infection, and it was 78% against severe LRTD. So we maintained the efficacy over 2 seasons. Last Monday, very important is last Monday data were presented for season 3 in the US, and it shows that there is no difference between season 2 and season 3, which means duration is sustained over 3 seasons. So this is reassuring that one shot gives you protection for 3 years. What we do not know currently is when to do the booster vaccination. This is still under study. Hopefully it will come with a result in the years to come. But currently we know that one shot given at the now will protect you for 3 years against severe outcomes and against lower respiratory tract disease. But hopefully also the efficacy is sustained also for the severe outcomes. Any vaccine will give you some local reactions and very mild systemic reactions. I mean, looking at this data would indicate, well, that it's really painful. It's not painful. I mean, patients have to report anything once they are included in the vaccine trial. So we will be asked for pain, erythema, and swelling. And you see there was a difference in the local reaction in pain between the vaccine group and the placebo group, but this was not really relevant. I mean, none of the patients had a severe problem due to local pain. So it's very well tolerable, and patients did not complain. This was the local reaction. What about the systemic reactions? If we compare them to the groups placebo and vaccine group, we see a little bit of fatigue, we have a little bit of myalgia, we have a little bit of headache and arthralgia, very little fever, but overall the tolerability of the vaccine was excellent. Patients, our subjects did not complain, and I can tell you that our subjects would complain if there would have been an issue, but they did not complain, which means it's well tolerated. And as we've just started now in Germany, rolling out this vaccine in 70 plus, 60 to 74-year-olds, we will certainly get very good feedback regarding this vaccine and the use of this vaccine in the general population. Important point is, and it's has already been mentioned, I think you mentioned about the combination of vaccines. What about co-administration and combination vaccines? Well, there is no combination vaccine ahead, at least in the next couple of years, so we will have to do with left and right. And left and right is not an issue. I mean, one side, the other side, it's not an issue. An important point is you can co-administer, and we look at the co-administration with seasonal flu, which you use here in Saudi, in England. We also look at the adjuvant flu, which is used in the US and Europe, and we also look at the co-administration with high-dose flu, which is used in the US and Europe. And we have demonstrated that you can co-administer the vaccines without interference, which means the immune response to flu and to RSV is not altered by the co-administration. So you can apply both vaccination left and right. And you should do this because that's important. This is something which will keep patients healthy. And we want our elderly to stay healthy. That's the important thing. Good news also, there is a recent study which has been presented a few weeks ago in Barcelona. Presenting the data on the co-administration with Shingrix, the zoster vaccine. And also there was no interference and tolerability. There was no difference in the co-administration of Shingrix and RSV. Tolerability was fine, which means you can also co-administer Shingrix and RSV at the same time. We have no data on triple. So you have to
عندي ديسك عجل بطاطا واش كان بطاطا
but at least left and right is fine. It's easy to prepare the shot. You've got your lyophilized vial, and you've got the adjuvant, you mix it and you shake it and administer it. Very easily done. You've got a sticker which you can apply to your vaccination booklet, or to the documentation. There are 2 stickers on the vial, also very helpful, and then that's all. So let me summarize key findings. We have clearly heard this afternoon that RSV is an important cause of disease, of severe outcomes in elderly, causing hospitalization, intensive care, and death. We've also heard from you that there is no systematic testing in Saudi. I can tell you some data from Germany. RSV is now notifiable, and our hospitals do multiplex PCR on all patients with respiratory symptoms. So we've got a very good idea on the incidence now. And from November 22 to June 23, we had more than 12,000 hospitalizations due to RSV. among them 1,500 admissions to the ICU in 60 plus. So this gives you an idea of the burden of disease. And I assume that the burden is similar in Saudi. It's probably in the same range. We have 80 million, you have 50 or something. So you can break it down a little bit, but at least you've got an idea of the overall burden of disease. So it's really important, vaccine. We have demonstrated very high efficacy and consistent, durable efficacy over now 3 seasons against LRTD and also for patients with one or more than one comorbidity and also for RSV A and B. One dose gives you good protection over now 3 seasons. This needs to be amended. It's only 2 seasons now, but we have data on 3 seasons. There is no waning of efficacy over 3 seasons, which is also important, and the protection remains stable over the age groups. Also very good news. And the safety, there's very little to report. Vaccine is well tolerated with an acceptable safety profile, and it can be co-administered with seasonal flu and the other 2 flu vaccines, which are specifically designed for the elderly, and also with zoster vaccine. So with this said, I would also ask you some questions whether you've been able to remember the important key data which you can report to your patients once they ask the doctor how good is the vaccine. I'm giving you, so now let's recap for session 4. Scan the code, and I will give you the first question. What was the vaccine efficacy? So I can't remember, go outside, you will see it on the posters. What was the vaccine efficacy against respiratory tract, against RSV, against the severe form of RSV? And the correct answer will come in a second. And once again, we're talking about a vaccine for elderly. So having such high efficacy in a vaccine for elderly, I mean, that's unique. It's like shingles, same level of efficacy. And the result is 94.1, you're correct. 62. Oops. I think you better look at the posters again to see the results. Okay, 94% would be correct. Then next question, RSV is indicated for prevention of LRTD caused by RSV subtype. What's the correct answer? All subtypes or RSV A and B? And the correct answer is all subtypes. There's some fluctuation between the occurrence of RSV A and B worldwide. There's kind of fluctuating over the seasons, but we can now prevent both subtypes with one vaccine. And the result is correct, 94%. That's correct. And I think I've got a third question. RSV is indicated for all patients 60 plus and can be co-administered with inactivated seasonal flu vaccine. What's the correct answer? I told you left and right. So it should be reaching almost 100%. So we're almost getting there. And the correct answer is true. You can co-administer. Yes. Thank you very much.
a breakthrough. It's a breakthrough because even with the first question that Dr. Schwartz mentioned, what's the efficacy of the RSV vaccine? The lowest number as an option he put there was 57%. Even with the 57%, I would be happy with the results. 94% protection against a lower respiratory tract infection. That's a breakthrough number. It means it's unfair for our patient not to get this vaccine, especially if they're 60 and above, especially if they have a cardiovascular disease or a chronic respiratory disease. It is unfair because this could be deadly for them. And that's why it's recommended by the Ministry of Health, by all guidelines. It has an efficacy of 95%. It can save lives. Not only this, it's not even a yearly vaccination. Dr. Schwartz now updates us with that maybe it will be protective for 3 years. So let's get the last questions on board. Please scan this QR code and let's get with the first question. After this event, how confident are you to protect your patient and vaccinate with adjuvant RSV vaccine? Is more confident, same, or less confident? And in one word, what is the most valuable insight you gain from this event? I love these words. I love the words that you guys talked about here. Not only is there informative, especially for us, but it's also give us a confidence. This is a new vaccination, a new era. And it's a new vaccination, a new era, and I think we should be informative and confident in giving this medication to our patients, especially those with special population, elderly, and or with comorbidities, cardiovascular and respiratory. I think with this we can go for the panel discussion. So I would like to invite our panelists to the floor to accept questions from the audience. And the floor is for you guys to ask us any question regarding the RSV overall, the danger of it, and the importance of vaccination. So can we spread the microphone? There's a question there.
Here. Hello here. Sí. Here.
I have some comment and question. I'm from King's College University before and now in Della Hospital. My question first, the outbreak of RSV virus, it happened after coronavirus when we lack of crude immunity. And before that, we didn't hear about it, this outbreak. So it's now after people open together and talk to each other and we meet a lot, that the incident will be less like what present in the year 22, 23. This one question. The other point for me, that there is another vaccine also for children, for pregnant women. I think in the 32 to 36 pregnancy for pregnant women, but usually it's from other company. This one. The last one comment, which was I think I'm interested with it, that the incident, the study showed there is increased incident of Guillain-Barré syndrome. And there is a suggestion that there is a post-marketing study to say if there is increase really of the incident of Guillain-Barré syndrome in these patients who received the vaccination. So did anything happen or not? The last one is the recommendation. I know the CDC in United States, they recommended for age 70 everyone, from 60 to 70 if patient have risk patient, high risk patient, have one risk patient. But for patient who was healthy, for example, they should be discussed with the patient and it's negotiated. The patient can take it or cannot take it because the evidence is not strong and there's also worried about the side effect. So please comment please. Thank you very much for this excellent talk. We enjoyed and we learned a lot.
So we'll start with the first question in terms of the outbreak of the RSV, especially after COVID. So Dr. Jawahir and Dr. Lay, what do you think, especially that we're talking about the local market?
Honestly, we don't have a surveillance for the RSV, so we're not quite sure what is the incidence of RSV among the kingdom in the past few years. However, we all noticed as a healthcare provider that the incidence of other respiratory viruses has declined with the mask during the pandemic of COVID. And then after the masking was alleviated later in the COVID pandemic, we start seeing other respiratory viruses that include RSV and influenza. And I think from the clinical perspective that it is not a matter of outbreaks rather than, yes, in the era at which we were wearing masks and the COVID pandemic, most of us were not exposed to RSV infection and influenza because of the masking, and then later when the precautions was discontinued, you start seeing those numbers of increased RSV. But I'm not aware of the total number of RSV incidents within the kingdom in the past at least 2 years. And we try to have it in our hospital as well, but we fail to do so since not most of the respiratory infections test for RSV and other is done as a routine basis.
The prevalence of the virus is every year. We see it in pediatric every year. The awareness is increased after the COVID, and when the vaccine is approaching, people more talking about it and maybe more investigation, so people appreciate more people affected with the virus. But I believe it's not outbreak, it's every year. The prevalence is not increasing, it's the same.
Maybe I could contribute some experience from Germany. In 2021, we had in 2021, we had hardly any RSV. We had then an out-of-season outbreak in summer. Usually our season starts in October, November. But we had an outbreak in July, which continuing, which is a reflection of the missed contact with the virus. And since 2003, we're back in unusual seasonality. So now we're back in the usual times before the pandemic. So RSV will stay with us forever, and it has the usual pattern.
So question 2 and 3 will be first to Dr. Schwartz regarding first pregnancy, especially with other vaccination, and the incident of Guillain-Barré in this vaccination.
Okay, regarding pregnancy, you know that the other vaccine, the bivalent vaccine, is indicated also as a maternal vaccination. The position of STIKO at that point currently is that there is limited that the data are not yet complete and there is no evidence yet that it should be used in pregnancy, but it's licensed for use in pregnancy, that we have no recommendation. STIKO made the decision to use the monoclonal antibody for the toddlers and not the maternal vaccination. But it's licensed, you can do it as well, but the limitation is you have to plan your pregnancy very carefully, because you may end up in 6 months without efficacy if you come down the wrong terminal year, because the efficacy is only lasting for 5 to 6 months. So it's a limitation, but it's one option as well. The second point, Guillain-Barré. We had an incidence with the Pfizer vaccine of 25 per 100,000 and an incidence initially reported for the GSK vaccine of 10 per 100,000. This was discussed, but at the end of the day, it was clearly stated that Guillain-Barré is not associated with RSV vaccines. It's something which you very often find during vaccine trials, that there is an over-reporting of unusual findings, but in fact we have not seen anything. And after the rollout of these vaccines last year in summer, there was no increase in Guillain-Barré syndrome seen in the countries which vaccinated.
Last question is regarding my age. And this question also put us in mind, because those studies were done mostly in industrialized world, where people above the age of 60 and 70, they're still healthy. But that might not be representative of our population, because we have people above the age of 50 with lots of comorbidities, whether stroke, cardiovascular disease, etc. Now, I'm happy that Dr. Trust talked to us. Maybe we can put the vaccination a bit early. So what do you guys think? I mean, we have those people 50 with list of comorbidities, diabetes, hypertension, cardiovascular disease, etc. Do you think that maybe it's beneficial for them to get it a bit early on? Dr. Jawahar and Dr. Noy.
I think a lot of our population, they are really sick, and the access is not always easy, especially when it comes to public in the public health. So I think a lot of majority of, it's not a question of most the patient above 60, they have diabetes or other comorbidity. The vaccine is good for 3 years and it's the side effect is less. We always go with patient-centered care, as I mentioned. Even if the recommendation is high, we need to convince our patient, but first we need to be believing that the vaccine is safe and is effective. I believe above 60, we have a lot of comorbidity in our country. Majority of them, they benefit. We'll go and discuss with them. Maybe less watching for the patient when it is less than 70 or 75. But I believe if we can give him, I will give him. Before 60, I think that maybe diabetes will come. The people with diabetic or severely diabetic or type 1 diabetes or severe asthma or COPD, maybe we'll have the data that and the guidelines recommended younger. I believe it's coming, but for now, we don't have the guideline. But for sure, these people would be suffer and maybe die premature because of they have RSV with type 1 diabetes, for example. But we need the evidence and the guidelines for it.
I think we have a question in the floor.
Thank you. I'm Dr. Haitham Najjar, consultant pediatrician at Kidney Hospital. I know this session is mostly for adults, but definitely related to our children too. My observation question is like this. In certain season of the year, sometimes the admission to pediatric ward 30 to 40% in infants related to RSV virus. And as you have mentioned clearly, that incubation period some adults to be extended to 3 to 4 weeks. So it means those kids who have the RSV, even if they survive, still they might spread the infection in the elderly patients, elderly family members. So being as it may, the vaccine is highly recommended for adults. So what is how we could extend the scope of vaccination for children, infants? So not only for premature babies and, like my colleague said, for pregnant ladies who are at risk. So I guess part of the prevention is really to consider giving the vaccine to kids too. I know the dilemma is a price sometimes, but being admitted and isolated. Frankly, if you go to any pediatric floor during the season of RSV, all the patients are isolated and all the house staff will be covered with gowns and masks and gloves and you name it. So I'd like to speak or to hear from you what is any one of you, how we could see the program and what's we have now and for giving the vaccine to children. Thank you.
Yeah, so this is an important question, especially for infants. Especially we have a working vaccination in few terms. Overall in infants, because it can also prevent the spread to the elderly, those people we would like to protect, so that's one. Or we can also talk about infants and children with comorbidities, things like cystic fibrosis, asthma, etc. So what do you guys think? Let's start with Dr. Schwartz, and then Dr. Luay.
I can start. We have a general recommendation to vaccinate all children in the first year of life in Germany since summer this year, and we're just about to roll out the program for pediatricians, which will be a challenge because we have 800,000 children to vaccinate every year, which is quite some tedious work for the pediatricians. But there's consensus that they will benefit because every year we have these outbreaks of RSV in our hospitals, blocking our hospital capacities, also blocking the pediatrician offices. So we have to do something about RSV, and we now have the monoclonal antibody, which is very efficient and can prevent RSV. There's very good data from Galicia in Spain, where they vaccinated last year all children in Galicia, and they had an 80% reduction of hospital admissions, which is fantastic. So you can really wipe out RSV also in the pediatric population. But you have to go, and I agree, it's currently very expensive, but it's worthwhile and it's cost-effective probably.
It's coming for sure, mostly, and as I mentioned in my presentation, most of the mortality is with the elderly. I agree pediatric is admitted to ICU and in the ward, but we take care of them. Luckily, their mortality is really rare, but it's coming. So it's first stage for people with high mortality, more born to have complication, and then it will come for sure.
The RSV vaccine in pediatrics and the and to prevent also the maternal transmission to the babies coming soon, inshallah.
Excellent. There's another question there.
Thank you so much for the very comprehensive presentation, and for me, for my own, I get a lot of information and data from the presentation. My question regarding the effectiveness, we actually many slides showed the efficacy of the vaccine, and please can you highlight the issue of the effectiveness in the real life? This is the first question, and the other one, assuming that if you have a good coverage of the elderly by RSV vaccine, is it has a positive impact for the children? And we know that the only available now is a monoclonal antibody for children. So if you have a high coverage rate for the elderly, is it has a positive impact to prevent the disease in the children? Thank you so much.
I will start with the second part of the question. By vaccinating an elderly, does not prevent transmission to the child. So this is you protect individuals. So the elderly is protected, and you have to vaccinate the child as well. That's one thing. And the second point about effectiveness, we now have already an analysis from the first year of the use of this vaccine, of these vaccines, both vaccines in the US, and the effectiveness confirms the efficacy data from the clinical trials. So it's beneficial for the population if you roll out these vaccines in your elderly population.
There is a question also on the floor. Please go ahead.
Okay. First, I want to thank you about the good presentation, and really it give us enough information about the RSV vaccine. We don't know before. But I want to ask you first about the cost effectiveness of introducing this vaccine. We don't see any study about this, because introducing anything we have to know about the cost effectiveness. And I want also to know where this vaccine is already approved in the country, Western countries and our Arab countries, where they introduce it and use it already. And I think at the beginning of introducing this vaccine, I think it is at least for high-risk people who have comorbidity other disease, like diabetes or heart disease or lung disease, because I think it is post vaccine. So I think at least to high, not to health people. And other countries, when they introduce it, they adopt it above 60 or 70 or one dose every season or 2 doses, because this is related to the costs. Thank you so much.
Regarding health economics, CDC made a health economic analysis on the use of this vaccine in the US population for certain age groups, and they came to the conclusion that it's cost effective. So this has been done, and you probably have to translate the data to other populations, but you will always come in with the same calculation. I just mentioned to you before, we have 12,000 hospitalizations due to RSV per season, and that is costly. So this certainly outweighs the cost of the vaccine. That's the first point. The second point was general recommendation. We have recommendations throughout Europe. Some countries have 75 plus general for all and 60 plus with comorbidities. We have even a country like Austria where we have a recommendation 60 plus for all and 18 with comorbidities off-label currently, but they already have a recommendation for that. The vaccine is licensed in the US and Canada, also Australia, also I think Thailand and some other Asian countries like Taiwan, but it's rolling out everywhere now. So, and also in the Gulf region, it's licensed in Bahrain and Dubai.
It's not annually, just to add, as you mentioned, it's now the data has shown that it's good for 3 years. And I just wanted to stress it in the cost. The people who are admitted at this time, and we're missing a lot. This is in Germany here, and how much you can valuable of the people, the elderly, to mortality or to admit it in the ICU. I think it's really valuable. Within one mortality, that is a lot. It's intangible, making saving money. So I think it's really effective. We are underestimating how much is the disease, the prevalence of the disease. If we start to study it now, we will see it more and more. And I think it's costly effective, saving life, prevent elderly from ICU or the hospital. It's priceless.
You say it is licensed, but it does not mean that already they use it. They added to the vaccine schedule for elder people.
Like UK has also 75 for everybody. Some of the European countries have already adopted it for general recommendation, and usually vaccines are reimbursed in Europe. So throughout Europe we have recommendations now already. And also in the US you have recommendation, and Australia the recommendation is still pending, but they are using it also a lot now. So it's coming everywhere.
The US is recommended, the SF, as I showed the presentation, above 75 and 60 more than with comorbidity. ADA, the diabetic, they recommended, the asthma, the COPD institute, all they recommended at the age of 60. So the clear for sure above 75, everyone recommended, above 60 with comorbidity like diabetes. And I want just to remember, just review how many of your patient above 60 and doesn't have comorbidity. The percentage is low, that's not. Most of the above 60 in our community, they have some comorbid condition. I believe the majority of them, they will be benefit with their current recommendation. But if you want to stick with the recommendation, if you have 60 to 75 with no comorbidity, you may discuss it with them or wait.
There's one more point which I want to highlight, which you mentioned in your talk, which is not included in this health cost in the analysis of the costs. This is the important cofactor which RSV plays. We have a very nice study due to our monitoring. We see the annual RSV waves, then the break during the pandemic, and then it goes up again. And then we were looking at the number of invasive pneumococcal infections. and they really match the RSV waves every year, which means if you prevent RSV, you stop the invasive pneumococcal infections as well, because RSV is a door opener. You open the mucosal layers for the invasion of bacteria. So probably the benefit which you get by using it a lot is much higher than what we just calculated, because we can also prevent secondary infections, as you mentioned.
Any other questions on the floor? Yeah, please go ahead.
Assalamu alaikum, Dr. Abu Ubaida, physician from Prince Sultan Medical City. So actually my concern is about reduced immunogenicity for the co-administration, especially with the quadrivalent flu vaccine, and increase in reactogenicity. And if you know that actually, especially the case of acute encephalomyelitis, which occur during the studies, happen when they are co-administered together. However, from the other side, we know that all this is actually spread on the season, start from October to March. So I'm not sure if we have to space it by 1 month or we have to co-administer. I know a lot of bodies, they recommend the co-administration, but still this sometimes may actually influence or affect the acceptance of the vaccine by the public.
I mean, you have to discuss with your patient whether he wants both vaccines at the same day. But co-administration is a strategy which we've been using for many years, and especially co-administration of flu and also pneumococcal vaccine has been done and recommended for many years. So now we have RSV, you can co-administer with flu, and we've already started it, and we have recommendations from our NITEX to use any visit to the doctor's office for maximum use. So whenever you have the patient in front of you, use both arms, and it saves you one additional visit. And there is no risk whatsoever and no evidence whatsoever that you would increase the reactogenicity and also the problems for the patient. So it's all well tolerated. And I do not see any concern about co-administration.
Any other questions on the floor? Not, then there is lots of questions online. They go through the same theme. What is the contraindications to this vaccination? That's one. And can it be given for people with immunosuppressive status, specifically transplant, cancers, etc.? So what do you guys think?
There is no contraindication, no relevant contraindication. I mean, it's a killed vaccine. It's not a live vaccine, so you usually do not have contraindications with killed vaccines in general. You can administer killed vaccines to every immune-compromised. There's never a risk associated with it. You may end up with a lower efficacy. That is the only problem which you may experience, but there is no contraindication. Regarding the use of these vaccines in certain immune-compromised populations, there are additional data coming up in the next couple of months for various groups, like we had it with the zoster vaccine. The zoster vaccine has data on transplants, on bone marrow transplant, organ transplants, bone marrow transplants, in hematopoietic, in hematologic malignancies, and also now we have data on various autoimmune diseases. So these data will come in the next couple of months, but be reassured, immune-compromised condition is not a contraindication for this vaccine, and patients will benefit because they are at a high risk for developing severe complications due to RSV.
I believe this will be more recommended for younger population to take it. For elder, we will wait for the data, but there the most people will benefit from the vaccine. So just the safety, I think it's safe and no contraindication. So just waiting for the data, but they're the people that we're supposed to focus on to get the vaccine.
I do agree, and probably when it comes into the immune-compromised population, we have to weigh the risks and benefits, and also we have to decide about the timing when to give it after the chemotherapy and the transplantation.
Any other question here? So I do have a question. It's a bit of a selfish question, but hey, healthcare providers can be selfish. Now, influenza is also mandated for us as healthcare providers to prevent spread. Do you feel in the next few years, or even now, this will be also mandated to us, especially that we are rounding on these people, the elderly people who have comorbidity. Are we mandated to take this vaccination to prevent that spread exactly like influenza? What do you guys think? Bit controversial.
You are pediatric, I think it's must. I think for everyone, I think yes, especially if you're dealing with sick patient. With the pediatric to protect yourself and your. I think it's selfish for us. It's not from different angle. Like if you are exposed, you will expose it to your family. So I prefer to receive it and to be mandated if somebody has it. So why not? And a few years, hopefully it will be mandatory, and hopefully it will be combination. As Prof said, it's maybe next after 2 or 3 years it will become combination. I believe to protect ourselves, protect our patient, protect our family is a safe vaccine. I wish that.
With our experience of vaccinations and healthcare providers, I have my doubts whether this will be successful. But it would be a good idea. I personally really agree. And it should not only be the RSV, it should be flu, it should be pertussis, because we have the same issues with this transmissions in the healthcare settings. So, I mean, it's up to the physician, and he has sworn his oath, and that means.
Though it's not up to the physician. It's come to
but it's certainly a point worth considering, and I think we should discuss that whether healthcare providers should be vaccinated as well against all these transmissible diseases, especially in oncology or so.
And I do believe if you're dealing with geriatric people, so me as a pulmonologist, I feel that certain specialties needs to be vaccinated, not only to protect yourself and your loved one, but also for the patients admitted to the hospital with chronic diseases, not to spread such viruses to them. That's what I believe. That's why I thought about this in terms of influenza, etc. Dr. Lai, because this question was asked multiple times, currently the Ministry of Health, what's their recommendation for RSV? So where to get it, who to give it, and how often? Please, can you just reiterate on this, please?
Yeah, I think, as I mentioned, that we are lucky in our country that they are leader in the country that provide it for. So it's Ministry of Health, they provide it for everyone above 60 with comorbidity. So this mention highlight above 60. So if you are above 60, you go to your primary health care or contacted your primary health care, and you will have it. As Shingrix, we've been lucky that we have it, and it was easy, and it was advertised a lot, and RSV will be advertised. So the government make it really easy. It will be in all primary health care. I think as I know now, they have, there were more than one vaccine, more than one company. So they provided with the GSK vaccine, they give good amount at the start, and when they finalize the coating and the efficacy study, it will be provided. For now, if you want it, you go to Ministry of Health and you will get it. Soon, I believe GSK will give a good offer and it will be available. For anyone want it, it's available now in primary health care. I'm not sure if there will be shortages, a lot of people go, but I know now it's available, and I'm sure there's a lot of amount will coming. If you go for private, it's there. If you come like in King Faisal Hospital, we have it, and I believe most of it is from the GSK, and as we mentioned, it's safe. It for sure will be provided. For now, anyone want it now, it's available in primary health care. Just go to your primary physician and you will get it. And I'm sure the country, the government, Ministry of Health will provide it for longer time, and every year it will be provided.
So a question mostly for Dr. Jawahar. Do you think that we'll have campaigns inside the malls, outside for RSV, and to get the actual vaccination similar to influenza? Do you think there is a value behind this, or just leave it to the primary care and hospital? What do you think?
And I think that in most situations, the first responder to the healthcare system is the primary care, but also it's good always to educate the community about the risk of having such a preventable infection, and then that it will carry morbidities and mortalities. So having a campaign is always good. And A few days ago, I went through the Ministry of Health Twitter, and they already started tweets about the RSV vaccine.
Campaign in the era now after COVID is really, really important. We have example with the Shingrix. I'm telling you, in primary health care, every day have clinic, patients come and asking about the vaccine. When we come to discuss about flu vaccine, there is a huge resistance. So the campaign, I think, is a must, and we need, as primary care providers, as collaboration with the pharmacy company and the hospital and the private sector. I think we need to educate about the importance. It's helping a lot to get the message from different ways. They hear it in the radio, they see it in the mall. It will become easy barrier because we know in the primary health care we are busy with a lot of things, especially in geriatric patients. They come with a lot of comorbidity, a lot of questions, blood tests, so you don't have a lot of time to convince him about the vaccine. So if the patient come to my clinic and is already ready, it will help me a lot to give him the vaccine.
I think the power now is in the social media rather than having like physical campaigns in the mall.
Exactly what happened with the shingles vaccine, because they got one of the influencer who talked about this, and every single person knows about it, and they come to the clinic to get that specific vaccine. When I have the severe asthma clinic, I try my best to convince patients to get the influenza vaccine, and they don't. And especially with this vaccine, you only have to give it once every 2 years, 3 years now, so it's a possibility. So I think we should work harder in terms of campaigns to our population. So I think we covered all of the questions in terms of thematic. I'll give the floor to you guys if you would like to end with a few sentences on this. Right?
So, again, I hope everyone today will agree about the messages we try to transmit it today. Geriatric patient, as a geriatrician, I saw the patient. Even when I was practicing the state, people admitted we don't know why. They have a pneumonia, ICU, some of them will lose them. Some of them, they get complicated. At least the delirium, and it takes weeks after the pneumonia infection. It's really costly. The vaccine is available, it's safe, and it's every 3 years. I think we as the care provider, we need to believe in the vaccine, and if we believe in it, we will help our patients to receive it.
In the last few years, we learned a lot about the relevance of RSV for the elderly. We hadn't thought about that before. We learned this during the pandemic. And now we have a vaccine already available, and knowing how severe the outcomes can be with RSV. You are really lucky in the kingdom that you have got the vaccine available for free and for your population. And I truly believe that it will be a successful rollout of this vaccine, because breathing is important, and if you can't breathe, that is a problem.
I echo what my colleague said. If I want to add one thing, is درهم وقاية خير من قطار علاج. So preventive medicine is where to go, and preventing the development of infection is very important for us to have a better quality of life and a healthy life during our seniorhood, inshallah. So I would recommend everyone to have the vaccine when they reach the age of 65, whether they have any comorbid diseases or not.
So hopefully by now, we talked about the RSV, that it is a deadly virus, especially for elderly, especially for people with cardiovascular and pulmonary diseases, because it exacerbates those diseases and it can cause them, in fact, especially for people who are admitted. So we know this. Now RSV is bad. We now know we have solution for this. We have solution with a vaccine that's 95% effective against it. These guys use the carrot, but I'm going to use the stick. It's unfair for your patient who's above 60, especially with comorbidities, not to receive a vaccination from you guys, the primary care physicians, the internists, the pulmonologists, etc. If you have a 60 and you see your patient is above 60, please just give them the vaccination, especially that we have it for free in this country. At least point them to where to get it. That's our job, our duty coming from these sessions. And with this, I would like to thank our panelists, more importantly, you for attending this session, And lastly, would like to congratulate GSK for organizing these sessions. And with this, Jum'ah Mubarakah and Assalamu alaikum.